From Ramaya Medical College, Department of Surgery, I welcome first of all our President, Dr. Venkatachala, and our Secretary, Dr. Harish, for this CME program conducted by the Department of Surgery, Ramaya Medical. Thank you and welcome to the program. And I introduce Dr. Nanda Kishore Alva, who will be presenting the Surgical Society program with the surgical pathology in thyroid malignancy. He is a professor, a senior professor in the Department of Pathology, Ramaya Medical College. He has got a vast experience. And I introduce Dr. Nanda Kishore Alva. Thank you. So we'll start the program. Yes, Dr. Alva.
Next.
Can I have the pointer?
I'll do the point.
Focus marker. Yeah. Fine.
A very good evening, ladies and gentlemen. A very warm welcome to the Surgical Society of Bangalore meeting, monthly teaching program of the Surgical Society. And thank you, Rudresh sir, for giving an introduction. Respected President, Dr. Venkatachala, respected Honorary Secretary, Dr. Harish, and all the participants of this meeting. At the outset, I would like to thank the Society for giving an opportunity to just to speak to all of you on this very interesting topic of surgical pathology of thyroid malignancy. Well, when Dr. Rudresh talked to me about this, which topic we had to take up, then we had a discussion on this topic on surgical pathology, which will be one of the very important and commonly encountered surgical disease and commonly encountered problems in the clinical practice, where surgeons day in and day out generally come across the so-called goiter and hence keep a suspicion of the thyroid malignancy in this particular goiter. So we thought we should take up this subject for the benefit of the postgraduates, especially in particular, and hence this topic of surgical pathology of thyroid malignancy. Ladies and gentlemen, greetings from our college, Ramaya Medical College, Bangalore. This particular slide I had kept to just give a insight into the classification of malignancy in thyroid. In fact, the goiter is the commonest presentation of thyroid disease when the patient comes to a surgical OPD. I'm not going to give a complete presentation of various malignant lesions, which happens to be papillary carcinoma. We have got the follicular variant, torso variant, diffuse sclerosing type, encapsulated type. We have follicular carcinoma, overtly invasive and minimally invasive follicular carcinomas. Rare carcinomas like Hürthle cell carcinomas, Of course, anaplastic carcinomas, giant cell variety, small cell varieties of anaplastic carcinoma, medullary carcinoma, very common one, and other miscellaneous malignancies like sarcomas, lymphomas, squamous cell carcinomas, mucoepidermoid tumors, clear cell tumors, plasma cell tumors, and lastly, the metastatic malignancies which are coming from various other organs like ovary, kidney, colon, and malignant melanomas. What I'm going to focus is the commonest lesions which presents in the surgical OPDs, the so-called thyroid cancers, which account for the maximum percentage of cancers which we see in thyroid. Number one is papillary carcinoma. Number two is the follicular carcinoma. Number three is medullary carcinoma. Number four, anaplastic carcinoma. And finally, lymphoma of thyroid. In today's presentation, I'm going to discuss closely in detail about these 5 types of carcinomas because these are the commonest malignancies you are going to encounter in thyroid. In particular, because this is the surgical pathology, I'm going to concentrate on the gross features, microscopic features, the pathological approach. What is the pathologist perspective in approaching a thyroid cancer or a thyroid malignancy, and in turn, what a pathologist can in turn give a surgeon the inputs or the pre-operative inputs and the post-operative inputs, how these carcinomas has to be dealt as far as the diagnosis of these cancers are concerned. Let us start with the first malignancy, the thyroid papillary carcinoma. Well, thyroid carcinomas, papillary carcinomas are the commonest malignancies that you see in thyroid. Most often they are seen in young age, middle age, and even in old age. And of course, presenting as commonly a solitary lesion in the thyroid in front of the neck. Majority of these patients generally walk into surgical OPDs without any specific problems. And many of the times, it is of possibly a cosmetic importance. Somebody would have noticed a solitary nodule in the front of neck. And this is one of the presentation of the thyroid malignancy, which is a papillary carcinoma sometimes, which is histologically diagnosed. But this type of carcinoma can be missed many of the times, even in surgical OPDs, because they may not present with any of the nodule or goitrous lesion in thyroid, but instead they can present as a small or medium-sized nodules that are present in the neck areas, which could be the nodes or the lymph nodes in the cervical areas. Presentation of papillary carcinomas are varied. And just I'm putting up another 2 to 3 pictures to see how a papillary carcinoma grossly differs from other goiters which we get in surgical pathology department. If you look at this picture, possibly this is one of the commonest lesions in thyroid which you encounter. But if you see, patient is happy, surgeon is happy, pathologist is also happy because he is just seeing a single nodule or a single cyst which is just filled with colloid. This will be a colloid goiter, definitely, histologically to be confirmed. And definitely, surgeon will be very happy after operating this if this has caused a cosmetic problem to the patient. This is another presentation of an goiter which we commonly see in pathology museums, pathology's grossing stations, multinodular goiter. If you cut across this tumor-like lesion, the goiter, you find that there are multiple nodules here, but there is no tumor. Again, happy surgeon, happy pathologist, and we are giving good news for the patient. And we have taken this, knocked this thyroid out, and this is invariably a multinodular goiter. Why I have put this picture is how a carcinoma or how a neoplastic disease of a thyroid differs from a non-neoplastic disease of thyroid, wherein in non-neoplastic disease, it is not a single nodule. It is not a solitary nodule. These are the multiple nodules of varying sizes. And if you look into each individual nodule, and each nodule has got multiple small, tiny cysts, which contain variable number of chlorides. And if you look into the areas which are directly dividing these small cysts, they are actually fibrous tissue, which is formed as a component of multinodular white. Please remember, to all postgraduates, if you cut across a thyroidectomy specimen on OT in the OT table, and if you see this kind of picture, possibly you are looking into a non-neoplastic lesion, a multinodular white. This is how it looks from the outside view, wherein outside you see areas of congestion and multiple nodules of varying sizes. You are not very sure you have a single nodule which is gray-white in coloration. But if you cut across, it is this picture what you see. So you are going away from what is called as the neoplastic lesion of thyroid. Yes, surgeon and patient are happy. But a papillary carcinoma, which can be an incidental as small as a very occult tumor, less than 1 centimeter, less than 0.5 centimeters. And we see in pathology crossing stations, some as small as 0.1 centimeters as a small typical white dot. Please remember, this can be one of the presentation which is called as an occult tumor. And this tumor are the one which are commonly missed by FNAC, commonly missed by the clinical examination. But whereas mass in the neck, commonest way is papillary cancer presence is a mass in the neck wherein patient present as a single or sometimes multiple nodules. Glands on the side of the neck. The spread of the local gland, sometimes called as the lateral aberrant thyroids, is also one of the ways of presentation. Local and distant spread can be a presentation of papillary carcinoma, but remember, the local lymph nodal spread is the commonest presentation of papillary carcinoma. If you look at the pathologist's perspective in papillary carcinoma, many a times we see lesions in the neck, in the both sides of the neck, which are generally palpated and thought that they are lymph node. And they are not solid in nature, they are not firm in nature as you palpate a lymph node. You must realize that papillary carcinoma metastasis can be a cystic metastasis in the lymph node. Lymph node need not be a firm lymph node which is present in the neck. It can be as well as a cystic node. And please remember, there are two conditions in which you find cystic lymph node in the neck. Number one is papillary carcinoma. And number two, if there is a metastasis from a squamous carcinoma, primarily in the aerodigestive tract. So, clinically, when you examine, when you see from the pathologist's perspective, you must understand that there cannot be any tumor in front of the neck. There cannot be any firm lymph node nodule by the side of the neck, in which case, both can be a presentation of papillary carcinoma, rarely. If you look at this specimen, you see papillary carcinoma coming as two nodules here. Very beautifully, a very large nodule here. And this nodule contains multiple cystic components. This is what exactly I was speaking about. Both the primary tumor as well as the metastasis can present as a cystic papillary tumor. And if you see these areas, you see multiple papillary excrescences which are protruding from the wall of the cyst into the cyst. And a small nodule here, possibly around 1 centimeter in diameter. And if you take a section from here and study under microscope, definitely you will have an area of a papillary excrescences which leads to a multicentric papillary carcinoma. So papillary carcinoma can be unicentric or it can be multicentric. It can be a small nodule or it can be a large nodule, or it can be as small as less than 0.0 centimeter, which we call them as occult carcinomas of thyroid. If you look at this, there was possibly a very large single nodule, and if you look into this nodule, these are the typical papillary excrescences, what you see in the pathology glossing stations, and this is the normal thyroid, and this is a large cystic lesion with multiple papillary excrescences. This is another picture which shows a single nodule in the thyroid. You can see the normal thyroid nodule over here, and you can see a large gray-white nodule, small area of cystic spaces, and there are gray-white areas, multiple papillary excrescences looking into the cystic lesion or forming gray-white with a tiny cystic areas in the space. And this is another presentation of papillary carcinoma. While putting this, all the different lesions are over the OT table, possibly as a resident, you can just cut across this lesion and see or suspect or tell the operating surgeon that possibly you are dealing with a papillary carcinoma, and you can identify without a pathologist's help that this could be a papillary carcinoma. This is what is actually important in this venture. Well, preoperatively, solitary nodules are generally referred to pathologists to say whether this is a papillary carcinoma or not, whether this is a neoplasm or not, or whether it is a non-neoplastic goiter. A very tough job for pathologists. But papillary carcinoma is one carcinoma which can be easily diagnosed, detected by a simple, single outpatient office procedure, it doesn't take much time, which doesn't give any pain to the patient. In fact, just a needle prick. And you get these cells, you are seeing the cells which are pleomorphic, varying in size, and you are seeing the cells which contain a very beautiful intranuclear inclusion. And this is called as intranuclear cytoplasmic inclusions. And this is very, very typical of papillary carcinoma. You make a diagnosis of papillary carcinoma by looking at this very typical classical psychological feature. Another very important psychological feature in which we make a diagnosis of papillary carcinoma is what are called as grooving in the nucleus. If you look at this nucleus of this aspirate, you can see a grooving that is passing across the cell nucleus. Many of the cell nucleus are containing grooves, and this grooving is a very typical presentation of cytological presentation of papillary carcinoma. And if you look into these cells, a sort of clearing can be seen in these cells, and this type of nuclear clearing with a grooving, with intranuclear cytoplasmic inclusion is a very typical feature of papillary carcinoma, in which we make a pre-operative diagnosis of papillary carcinoma. And if your pathologist says very confidently that this is a papillary carcinoma by FNE, possibly the surgeons could go ahead with radical neck dissections very confidently. Otherwise, you are not sure whether this is a papillary carcinoma or not, or otherwise patient has to go for second knife after your histopathology report comes in. Picture of a papillary carcinoma with a multicentric origin, with a large papillary carcinoma, which is gray-white in the periphery, yellowish in the center, possibly because of papillary excrescences, and some areas with small dots here, possibly representing as a calcified dots in papillary carcinoma, which we call as Samama bodies in histopathology. That's a very typical of papillary carcinoma. Very, very classically, papillary carcinoma is compared with multiple papillae or finger-like projections. And a typical nuclear feature of a papillary carcinoma, which is called as a little orphan Annie-eyed nucleus, and the nucleus goes for an absolute clearing, and you can see the papillary fronts in this picture. You can see absolute nuclear clearing of orphan Annie nuclei in papillary carcinoma. Carcinoma or papillary carcinoma with multiple papillary fronts and foci of calcification. Papillary carcinoma invading into the stroma of the thyroid. Invasion is a feature of malignancy. you can see the normal follicle, normal thyroid follicle with lot of colloid here, abnormal thyroid follicle with multiple papillary excrescences containing orphan anide nuclei. Look at this calcification in the center, which is typically what is called as Samama body, a calcified concretion that is seen in papillary carcinoma with multiple papillary fronts. Samama bodies are a very typical feature which are seen as also calcifying deposits in the tumor. Look at the striking and glaring, staring intranuclear cytoplasmic inclusion in the cells of papillary carcinoma. This is one of the presentation of papillary carcinoma, which generally released by FNAC. And the surgeon would have sent it as a multinodular goiter, and we find microscopically this a very small foci of papillary carcinoma. And these are the patients who go for second knife, possibly after the detection of final histopathology. So when we do extensive grossing of this specimen, you can find a very small, tiny nodule of gray-white nodule, less than 0.1, less than 0.5, and microscopically a foci of papillary carcinoma, which is called as micropapillary carcinoma of thyroid. And these are the ones which need special attention after the surgery. Once you receive a histopathology final report that there is a micropapillary carcinoma, which may need later on a radical surgery later on to have the dissection of the lymph nodes. So with this, we shall pass on to the next neoplasm, follicular neoplasm. Follicular neoplasms are very interesting neoplasms in the thyroid because they can be as benign as just a follicular adenoma, as malignant as a highly malignant, highly metastasizing potential of follicular carcinoma. Look at this picture. You have a thyroid gland which is which has got a normal thyroid field. Abnormally well circumscribed, well encapsulated thyroid lesion. Definitely this will be a follicular neoplasm. I'm not sure whether it is a follicular carcinoma or a follicular adenoma. Adenoma is benign, carcinoma is malignant. But if you talk about an adenoma, look at the capsule of this particular tumor. This tumor is giving a very thick fibrous capsule, and hence more likely that this could be a follicular adenoma in comparison to a follicular carcinoma, possibly as a resident. You can cut across this specimen on the OT table itself and tell the operating surgeon that possibly this could be a follicular adenoma. Please don't go ahead with extensive surgery for this. A very difficult lesion for pathologists to identify, because as we go on to follicular carcinomas little later on, I will tell you how it is very important for us as a pathologist perspective. Look at the normal thyroid, but look at a very well circumscribed nodule, possibly a follicular adenoma. There is no invasion of the capsule, and there is no foci of hemorrhage and necrosis here. Follicular thyroid carcinomas, tumor has a tan or light tan appearance, contains small foci of hemorrhage as it is seen here, but you are not seeing a capsule. Please remember, if you don't see a well circumscribed capsule, you are dealing with a carcinoma, or you are possibly dealing with a carcinoma, and it needs an extensive microscopic examination. Look at this picture. Hardly there is capsule. You can see the capsule here, but there is no capsule there. But this absence of capsule or the invasion of the tumor into the capsule is one of the very important gross features to suggest that it is a follicular carcinoma. If you look into the cytological picture of a follicular carcinoma, your pathologist can misguide you, please remember. Because it is very difficult for pathologists to say whether it is a follicular adenoma versus a carcinoma, because in both cases, cells looks absolutely very, very benign, very, very Papam looking cells. They are not pleomorphic. Look at this. You can see multiple follicles here. Little hyper, multiple follicles here, but there is no pleomorphism. But the looks can be very deceptive in such cases because histopathology is a must. And this is the area where possibly pathologists also err and sometimes overdiagnose and sometimes underdiagnose. So most of the times we save our skin by telling that by FNAC, it is just follicular neoplasm, not commenting that it is an adenoma versus carcinoma, which is a big headache for surgeons. Look at these follicles, very pretty looking follicles forming in an FNAC, thinking that it is a follicular adenoma possibly versus malignancy. This is a case of malignancy where the cells are slightly bigger, slightly pleomorphic. Yes, these kind of cases, we can confidently tell it's a follicular carcinoma, but at histopathology is a must to differentiate follicular carcinoma versus adenoma, because adenoma has got a capsule, normal thyroid, and abnormal proliferating follicles. But whenever there is a tumor capsule invasion of the tumor getting into a capsule, then with a normal compressed thyroid tissue, even if it is there, and these cells invading the capsule, indicating that you are dealing with a malignancy, not an adenoma. If you look at this picture of the thyroid adenoma, look at the capsule, very pretty looking capsule, closely compressing the thyroid adenoma lesion and normal thyroid at the other side. This is the normal thyroid and this is the tumorous lesion. But this tumor has not invaded the capsule, hence I would like to call it as adenoma. But in a case of malignancy, there can be cells which are very highly cellular or tumor with highly cellular areas. And this tumor can show prominent nucleoli, but at this point also difficult for a pathologist to say whether it is carcinoma or adenoma, because many of the times we detect carcinoma after the patient has metastasized, which is of no use for a surgeon, neither for the patient. But look at this picture. Extensive grossing is necessary to identify this very beautiful feature of a follicular carcinoma, which is called as capsular invasion. These tumor cells has invaded the capsule and gone outside the capsule into the normal thyroid area. Capsular invasion is a feature of malignancy. Look at the capsule here, tumor here, and invading to have a capsular invasion. This is a very important feature to call a tumor or an thyroid lesion as a malignant, especially when you come to a follicular lesion, vascular invasion or angio invasion. So you see angio invasion here, you see a large vessel here, and inside the vessel there are tumor cells. Follicular thyroid cancers with the typical angio invasion is a feature of follicular carcinoma. Medullary carcinoma, the third and the very important and interesting tumor of thyroid. These are the tumors which commonly get associated, as all of you know, men syndromes, with multiple adenomas of parathyroid, adrenals, etc. Medullary carcinoma of thyroid typically has got a different cytological feature, different morphological feature, different gross feature, with a solid pattern of growth, but do not have connective tissue capsules encompassing these tumors. And this type of tumor referred to as medullary carcinoma of thyroid, which has got a very typical gross feature. As a resident, you can identify or you can give a suspicion of a medullary carcinoma by cutting across the tumor and finding that the tumor surface is glistening. The tumor surface is has got a capsule here, relatively a capsule, well circumscribed lesion, a very, very glistening capsule, as if starch has been smeared over the tumor. When you find a tumor as if a starch has been smeared over the tumor, the first diagnosis, second diagnosis, third diagnosis happens to be medullary carcinoma of thyroid. Look at this picture of an FNAC. For pathologists, again, this is a challenging area to identify this tumor. But many times we focus on a morphological feature of the cell, which is a spindloid in nature. And this spindloid in nature of the tumor cells is a feature. Cytologically, you can diagnose pre-operatively a medullary carcinoma. Look at these spindloid cells of medullary carcinoma, very classical of FNA finding or cytological feature of medullary. But what makes the diagnosis of medullary carcinoma finally is the presence of these tumor cells amidst of this pink eosinophilic amorphous ionizing material, which are called as amyloid. You would have studied in your undergraduate days how an amyloid looks. Amyloid looks pink, eosinophilic, and this is the classical feature that you see in medullary carcinoma. Look at the amyloid in between the tumor cells, elongated spindle-shaped tumor cells with amyloid in between. Look at this amyloid, which is specially stained with Congo red. You know, Congo red, it intensively flakes of the amyloid with very reddish in color. And if you go for a birefringent study under polarized microscope, you can see that this amyloid takes of apple green birefringence under polarized microscope. A viva question for all the postgraduates: how to identify a medullary carcinoma under microscopy? The medullary carcinoma is identified by the presence of very typical amyloid, sheets of amyloid, which looks apple green birefringence. This is the apple green birefringence, what you see here, which is seen in the medullary carcinoma, which can be specially seen under specialized microscopes, which are called as polarized microscopes. And calcitonin expression is a feature of medullary carcinoma because it is arising from parafollicular cells, and calcitonin expression by immunohistochemistry, you can make a firm diagnosis, a confident diagnosis of medullary carcinoma. Fourth one, last but one, is anaplastic carcinoma. You come across these tumors very commonly in surgical OPDs and surgical practice, and you can identify this by looking at the clinical picture of these patients. Very highly aggressive tumors, ready to ulcerate, old age people, and patients presenting with cachectic features or cancer cachexia, they come very late, anaplastic carcinomas. Highly aggressive tumor, easy for pathologists to identify because they contain extensive areas of hemorrhage and necrosis. Look at this tumor, highly aggressive, very angry looking tumor with a lot of hemorrhage, lot of necrosis, no absolutely capsule, and very aggressive tumor involving the thyroid gland. An aggressive, extensive hemorrhage and necrosis and anaplastic carcinoma. Anaplastic carcinoma with whole thyroid involved, hardly any thyroid which is normally that is kept there for observation. Extensive areas hemorrhage, extensive areas of necrosis is a feature of anaplastic carcinoma. FNAC wise, it's an easiest carcinoma for a pathologist to identify because you find bizarre cells in this. Absolute bizarre cells with lot of Jane cells, and one cell doesn't resemble other. One cell is small, one cell is medium, one cell is large. We call typical pleomorphic tumor, which is a feature of anaplastic carcinoma in cytology. You can see large bizarre tumor cells in the background of colloid, pale colloid in this thyroid aspirate. Another aspirate which is showing very bizarre cells indicating thyroid anaplastic carcinoma, because identifying anaplastic carcinoma cytologically, pre-operatively is very important because surgeon has to take the decision of what kind of surgery he has to do, and pre-operative cytology is very important. Histopathologically, very easy to diagnose with highly pleomorphic cells and lot of tumor hemorrhage and tumor necrosis in the tumor. Coming to the last thyroid cancer, the lymphoma. Before this, I have to talk about this Hashimoto's thyroiditis, because it is these thyroiditis, these thyroid lesions, which generally progress for non-Hodgkin's lymphoma, though it is rare. Patient presenting with hypothyroidism, autoimmune, with very thyroid treatment, arterial cell changes, initial hashimotoxicosis can be there. Marginal zone non-Hodgkin's lymphoma can appear. Whiter's presentation and high TPO or anti-microsomal antibodies. Lymph nodes, lymphocytic infiltrates can be seen. Easy to remember about Hashimoto's thyroiditis. A very typical gross presentation of Hashimoto's thyroiditis is that if a thyroid resembles like cut surface of a lymph node, please remember, I have shown various types of gross appearances. But if on the OD, if you just cut across on the side of the table, if your professor has given you a specimen, please identify whether it is an Hashimoto's or non-Hashimoto's. Yes, there is a very definite feature. This typical picture of typical gray-white, looking like a lymph node cut surface, you are dealing with an Hashimoto's thyroiditis. Possibly advanced Hashimoto's thyroid is going to lymphoma, very, which has to be confirmed by pathology. Lymphoid follicle, Hurthle cells, pink eosinophilic cells. Instead of routine follicle cells, we go for pink eosinophilic cells. Large lymphoid follicles with prominent germinal center is typical feature of Hashimoto's. If we find these two under histology or microscopy, we make a diagnosis of Hashimoto's thyroiditis. Hashimoto's thyroiditis can be easily detected by FNA as well in pre-operatively. Look at these Hashimoto's cells with pink cytoplasm, bluish under PAP. This is a PAP stain, hence it is bluish. And background, you are showing as if you have aspirated a lymph node, lot of lymphocytes of varying stages of maturation. Some lymphocytes are small, some are big. This is called as follicular lysis, which is a very typical feature of Hashimoto's thyroiditis. Histology of Hashimoto's thyroiditis with large lymphoid follicle and Hurthle cells in the pattern. Why this slide about Hashimoto's is because certain percentage of Hashimoto's thyroiditis get into thyroid lymphomas, which is not good for the patients. It is rare, about 2% of extranodal lymphomas or less than 5% of thyroid cancers it constitutes. Typically found in older women, almost always they are of B-cell lymphomas. Non-Hodgkin's large cell B-cell lymphomas, accounting for 70 to 80% of type of lymphomas seen in thyroid. And the main ones are diffuse large cell B-cell lymphomas or March lymphomas. March lymphomas respond very well to chemo. They just melt like butter, but not these diffuse large cell lymphomas with high metastatic potential. Lymphomas in thyroid, in contrast to a Hashimoto's thyroiditis, just I will take this back to the picture of a Hashimoto thyroiditis, it just looks like a lymph node. But if you go to a lymphoma in a Hashimoto's thyroiditis, this looks like just like as if you cut the fish flesh appearance. Lymphomas typically present with fish flesh appearance. And this type of cut surface, possibly you can do on-table diagnosis or suspicion of a lymphoma. Possibly if you do a lymphoma diagnosis, the treatment modality will be different and the surgical modality will be different as far as the treatment is concerned. FNAC can show sheets of lymphocytes. Look at this pretty looking, very beautiful lymphocytes, and each lymphocyte is of the same size of that other lymphocyte. And this is how a lymphoma is seen under FNAC. Many times you can make a diagnosis of lymphoma or non-Hodgkin's lymphoma by FNAC pre-operatively. Possibly this will help the surgeon to plan the treatment of these non-Hodgkin's lymphoma arising from Hashimoto's thyroiditis. In histology, you see sheets of lymphocytes, large lymphocytes of all monotonous looking lymphocytes. And every lymphocyte resembles the other lymphocyte. And hence it is called as monotonous population of lymphocyte, which is a feature of a non-Hodgkin's lymphoma, which can be confirmed by B-cell marker of CD19 or CD20, which can give a confirmatory diagnosis of B-cell lymphoma. Ladies and gentlemen, so just to summarize, if you look at the malignancies of thyroid, papillary carcinomas, follicular carcinomas, medullary carcinomas, anaplastic carcinomas, and rarely lymphomas constitute common malignancies that is encountered in thyroid. And what I'm trying to impress upon here is a pre-operative diagnosis of these cancers by simple, safe outpatient office procedure of fine needle aspiration cytology is a very important diagnostic mode to make a diagnosis of papillary or any other type of cancers that you come across in thyroid, which can be diagnosed, which can be definitely confirmed by histopathology, in which case the treatment can be planned. It is very important from the pathologist perspective that there should be a good communication between the surgeon and the pathologist in treating each and every case of thyroid, because non-neoplastic lesions of the thyroid versus a neoplastic lesion. In the neoplastic lesion, the so-called malignancies versus the benign makes a lot of difference for your patients as far as the surgical treatment, later on medical oncology treatment is concerned. Thank you very much. And I thank the entire team of Surgical Society of Bangalore having given an opportunity to share my few views and just to tell you what is the pathologist's perspective as far as the thyroid cancers is concerned. Thank you very much.
Now, PGs, any doubts? You need to ask, you can clarify things with Dr. Alva.
Dr. Alva, can you tell them about Bethesda?
Yeah, that's a fantastic question. Bethesda system of classification of thyroid FNs it has recently come in which actually there is a perfect communication and coordination between a surgeon and a pathologist if we use a Bethesda classification. In Bethesda classification, surgically, when you refer a patient for an FNAC, we divide this as a neoplastic, non-neoplastic, goitrous or non-goitrous, or if there is a neoplastic with a suspicion of the tumor or with a suspicion of malignancy. So, if you present a Bethesda classification, I cannot give you the entire classification now. It is not there exactly on my slides now. But if in the Bethesda classification, we say that whether there this is an hyperplastic module or hyperplastic malignancy or malignancy. The treatment modality, the surgical modality can change with a papillary carcinoma. A comment that yes, Bethesda system will assist the surgeon and a communication with a surgeon and a pathologist will give very useful information during the surgery as far as Bethesda classification is concerned.
Any other questions, please? PGs? Program. Anyway, thank you, Dr. Alva, for the excellent presentation you have given. You have actually made the life simple for the surgeon, giving excellent photographs where you can never miss a diagnosis. Very well presented. And thank you so much for the excellent presentation.
Thank you, sir.
Thank you.